Okay, we're ready to start. Good afternoon, everybody. Uh, Welcome to what I think will be a very exciting afternoon session of the Congress on one of the hottest and most debated topics of breast surgery, surgical management of the axilla. We are very lucky this afternoon. We have with us a truly stellar group of international experts who I think are going to enlighten us on the topic. And let me call first Mr. Yazan Masanaf, a consultant oncoplastic breast surgeon from the UK, who is going to speak about upfront surgery, surgical management of the axilla in upfront surgery. Mr. Masanaf.
Thank you for the invite. It's great to be here in Greece again. I'm going to talk, I've been given the task of talking about surgical management of the axilla in upfront surgery. And in the first instance, you think, oh, this is a nice, easy talk to give, but unfortunately, it's not. So I'm one of the surgeons now in England, in Essex. I sit on few committees in the UK and Europe. The only disclosure I have is that I run those webinars on the iBreast book. They're all free webinars for everybody to attend. Some of those are sponsored by some of the companies, but there is no conflict of interest. So surgical management of the axilla and upfront surgery, to be able to understand that, we need to go back in history. We need to look at how we arrived here, because when we go back in time, you find that many things in surgery, many things in medicine, we're just reinventing the wheel. We're just looking at data that have been in front of us for years and years and ignoring it. And history does not repeat itself, but it does rhyme. And in the past, for centuries, whatever we do with breast surgery, everybody was doing clearance. But the story has moved on, and we need to look at the story from one size fits all to made to measure axillary surgery, and that's what we need to try to find. What is the made to measure axillary surgery that we need? Because in the past everybody had a clearance, but now we have the options from doing nothing to doing a clearance, but we need to fit those options to the patient, and sometimes it's not that easy. And all stories have a starting point, all stories have a hero. So the once upon a time for this is really with this man. So I think Bernard Fisher is one of the few people that understood breast cancer to the extent that we cannot still understand it. And many people remember him for the B6, but I think one of the most influential studies was the B4, and people ignored the B4 for years and years. And in the B4, what they've done, and we have 25 years follow-up data in that, is that they looked at operable cancer, clinically node positive, clinically node negative. They've done either radical mastectomy with or without radiotherapy, or simple mastectomy with radiotherapy. There was no difference. So if they had axillary surgery or not, there was no difference. The difference was if they were node positive, they did worse than the node negative ones. And at that stage, people started thinking about the axilla. Do we need to do less? But even they were thinking they were clearing everything. And the first question, instead of de-escalating, they started thinking, shall we do level 2 instead of level 3? But that's not really the question. The question is, do we really need to have clearances at all? And in only 30 or 40% of patients, we have positive axilla. Also, one of the studies that has been really ignored and not that appreciated is the axillary sample study from Edinburgh that has been published also about 30 years ago, where they used to do either a clearance for one arm, the other arm they did a 4-node sample, and if they were positive on the 4-node sample, they had a radiotherapy. And guess what? The ones that had clearance had higher local regional recurrence because the other arm had radiotherapy, and the axillary node clearance had slightly less axillary relapse, but not much different. And this is a beautiful timeline published in the Breast Journal only sometime earlier this year, a review by Tari King and the team from the States. And our starting time point for real de-escalation is the sentinel node biopsy. Why did it take off? Mainly because we had a new machine. It was the sexy thing to do. We just go into theater, we have the new machine, and we can find nodes, and we felt more important with that. And that's why it took off. But it changed practice. We had the Milan study, we have the B32, we have the Almanac, all showing identification rate more than 95% with a low false negative with axillary recurrence of 1%. And people started moving from the clinically node negative to doing sentinel node biopsies, but still clearing the axilla if they're positive. And then people start thinking, but if we're accepting 10% false positive rate, why are we touching the axilla? We're not seeing any difference. And that's where the Z11 came. And we know all the data from that. T1, T2, clinically node negative, wide local excision, 1 to 2 positive nodes, clearance or nothing, and there is no significant difference. But remember, all had radiotherapy to the breast, and the fields would have covered part of the axilla. And guess what? If you go back in history, the B4 and the Edinburgh study both showed that radiotherapy does work. So we moved to the sentinel node biopsy arm to doing nothing for the 1 to 2 positive nodes, but still clearing the axilla for the 3+, or nothing if it's negative, of course. And then you have all the barrage of studies, lots of studies looking at the same thing, from the Synodar to the Sinomag to the Posnock to the Autoshower to the Amoros, all looking at avoiding any further surgery, mainly if we have looked at radiotherapy. And we can know from the Amoros that there is not much difference in the local recurrence if you give radiotherapy to the positive axilla. Of course, in the UK, sometimes we catch up a bit late, so we still haven't published even the Posnock, but they finished recruiting. And the axilla post-neoadjuvant chemotherapy, I'm not going to touch on that. Viviana is going to give a lovely talk after my talk. But the thing that we have learned from the axilla post-neoadjuvant chemotherapy, we learned about target axillary dissection. And with the target dissection, we started looking at de-escalating the axilla even more. Is less more? And here, we started looking at the concept of doing no surgery and the concept of doing targeted surgery for the positive axilla. I think that completes the cycle for me. The cycle started with an SAB B04, went to the level 2 instead of 3 clearance, to the sample, then to the sentinel node biopsy, then Z11, and now we're going back to the omitting surgery, which was something that we knew it works from years ago. So do we really need axillary surgery in clinically and radiologically negative axilla? Lots of studies again. So the studies include the SOUND trial, Enzima trial, Book trial, SOPIT trial, and Nautilus, and Viviana is one of the authors of the SOUND trial. It's great to have her here. And we had Oreste last weekend talking about the SOUND trial in the iBreast book webinar. So it was a very nice talk by him. And we know it's a phase 3 trial, randomized trial. It's an international trial. Even parts of Chile and South America took part in this. About 1,400 patients, and we know that there is no difference. So we know that in his own words for Oreste, he said, we thought that the results will be good, but the results were even much better than expected. They were so good. About 1.6 ipsilateral recurrence in both arms, very similar, and there's no death from breast cancer. But this is a sub-cohort of patients of small T1 tumors that are radiologically node negative. Remember, there's always something to look on those lovely trials. It's a 5-year follow-up, which might not be long enough, but also they have great radiologists, because you look at the sentinel node biopsy positivity in the sentinel node biopsy arm, it's only 13%. So the radiologists are picking most of, or a big percentage of the axillary positive nodes before. And the question, so we know that for local control is not that important, but are we doing the surgery only for the local control? That's the question. If we're accepting for the Z11, 1 to 2 nodes not to do any clearance, some people are trying to look at it in a reverse order. What if we do an ultrasound scan and find only 1 or 2 nodes? Can we just do a target dissection of the axilla and apply the Z11 concept to it? And not sure where that will land yet, because there's not enough data. But if you look at the retrospective data, that's a beautiful paper by Boland from Ireland from years ago. They looked at retrospectively at their data. They had looked at about 430 patients, analyzed 350, and when they applied the Z11 trial, those old ladies that had clearances, only 40% or less had 2 or less positive nodes, and you apply all the Z11 criteria, they would have avoided clearances only about 8%, but that's 7-8 years ago. Prospective data, I think the only prospective data that we have and still not published yet, it has been submitted. There was a beautiful talk by Peter Barry from the Marsden in ABS last year, and in the experience in the Marsden, and they had done targeted dissection for 1 to 2 positive nodes on a upfront surgery in 97 patients. The sentinel node biopsy, interestingly, was not the marked node in 81% of the patients, which is very interesting. It's much better than the 60% post-neoadjuvant chemotherapy that they have locally in the Marsden. But 25% had completion clearance and 75% did not need to have that. And 70% of the ones that had clearance had residual disease. 25% of those had 3 or more positive nodes. Why is it important? We'll look at that. And there are some studies that are looking at that prospectively, from the Taxus to the Mutas in Spain to TADEN. There is no publications, but the provisional data from the Taxus. Remember, the Taxus has 2 arms. One is neoadjuvant chemotherapy arm and was upfront surgery arm. In the upfront surgery arm, they presented some data to suggest that 70% of patients that had residual axillary burden after their surgery. Remember, axillary operations, they are not therapeutic. They are mainly staging operations, and they are debulking if there is big problem in the axilla. But sometimes you end up now in the MDTs having those discussions with the colleagues. Do we really need the surgery for the oncology colleagues? And that's the fly in the ointment recently, because many of the systemic treatment options are based on axillary surgery, which is disappointing to see that some of those trials are based on axillary staging. Like the Monarchy, abemaciclib, they give it to high risk, mainly ER positive, HER2 negative patients. If they have 4 or more positive nodes, or if they have 1 to 3 nodes positive with T3 tumor, grade 3 tumor, or Ki67 more than 20%. And you sit in the MTTs, sometimes you have 1 out of 2 or 1 out of 1 positive nodes, and the oncologist will want you to clear the axilla just to know if they can give abemaciclib, which is something does not feel right in this day and age. And the other trial is the Responders trial, which looked at the utility of Oncotype DX in determining chemotherapy benefit for patients that have 1 to 3 nodes. So the other argument is that, we need to clear the axilla to know that there isn't 4 positive nodes, which is not a great argument. But that's something to think about. Beautiful paper by Tulani, who ran the APT studies and many of the oncology studies about the impact of Responders and the Monarchy on the surgical management of the axilla. And if you look at that from previous data, from the Z11, we need to know about 13% of the ones that had positive sentinel node had N2 disease. From MSK cohort of about 5,000 patients, they had about 16% of the patients that had N2 disease when they cleared the axillas. But also, if you look at the biology, the one that was ER positive, that went below 10% compared to a much higher percentage for the ones that were HER2 positive and triple negative. But remember, in those cohorts, many patients did not have ultrasound scan before their surgery. And remember, in the SOUND trial, if you look at the criteria from the SOUND trial, I think less than 1% of patients had N2 disease. So you're clearing axillas for less than 1% to get the abemaciclib, which does not make sense. In CIMA trial has not published yet, but in one of the posters and presentations, they showed the interim data suggesting that 0.3% of their cohort had N2 disease. This is a very busy slide. That's the NCCN guidelines. I never knew that the NCCN has put the targeted axillary and upfront surgery as part of their guidelines, which is interesting for me. So what they're saying is that if you have palpable node diagnosis or less than 2 suspicious nodes on the ultrasound scan, you still can do a sentinel node biopsy, which is very interesting. And that looks at all the different options for the upfront surgery. So for me, can we omit surgery can we omit sentinel node biopsy? Maybe in the future, but not yet for all patients. In some patients, especially small tumors, older ladies, why not? Why to put them through sentinel node biopsy? You have a T1 tumor in a 70-plus-year-old. Why to do that? Or even younger than that. Now, there will be some that you will do that to plan oncological treatment. So you cannot omit it completely in some ladies to be able to know if they need CDK4 and other treatments. But if you do a little operation for DCIS and you found that you upgrade that there's a small invasive tumor, you need to think twice before we're going back to that axilla. What about omitting the axillary node clearances in positive axilla and de-escalating to a targeted dissection? Well, if it's post-positive sentinel node biopsy, yes, you can omit the axillary node clearance, but in upfront surgery, I think you might need to have more data because those patients will have higher burden in the axilla. We still don't know how much is that high burden. I don't think it will change their axillary control. It's mainly because of the way we give our systemic treatments. That's where the discussion will be with the oncologists in our MDT. So for me, definitely for clinically node negative, radiologically node negative is sentinel node biopsy for most. Consider omitting in small T1s older Pleiades with grade 1, grade 2 luminal A. Some people even omit in excellent responders post-neoadjuvant chemotherapy, but something I'm sure that will be addressed later. For clinically node positive, then if it's post-neoadjuvant chemotherapy, please keep the node and consider TADS. In upfront surgery, some people will de-escalate for 1 to 2 nodes. We still don't do that where I work locally. So I hope that you felt that I had something to say. I did not have to say something. Thank you.
Thank you very, very much for the very clear and overview of the field in a short time. We'll save the questions and the comments for the end. So,
good morning also from me. We have the pleasure, the privilege, and the honor to invite Viviana Galimberti from the European Institute of Oncology. I think that everybody knows her, and to address the issue from the axillary management of the in the post-neoadjuvant therapy. Viviana.
Thank you, Caterina. I want to thank all the scientific committee for the invitation. It's a pleasure to be here with you to discuss this topic. So, sorry. So we know that neoadjuvant chemotherapy permitted us to de-escalate surgery, particularly in 40% we increase breast-conserving surgery, but also we can reduce axillary surgery, and this is the topic, because we may have a high PCR in both in the axilla and also in the breast. What about this patient that start with a negative axilla and remain negative after post-neoadjuvant chemotherapy? We can do sentinel node biopsy. I think we are all agree there is no problem, and this because all the studies have demonstrated that the identification rate and the false negative rate was similar to that we found in the upfront surgery, and so is accepted. There was no debate, I think, about this. No? But what about those cases in which we start with negative axilla, then progress, and or if they start with a positive axilla, then there is a mistake. Positive that remain positive. In this case, axillary dissection is the standard treatment, and is also confirmed by the Sangallen International and NCCN guidelines. But what is interesting that, as I said before, is in this case, so patient with a positive axilla at the beginning, that downstage after neoadjuvant chemotherapy, can we de-escalate surgery? Of course, because we know that in 30–40% we may have a negative axilla, and so we don't have to do an useless axillary dissection in those patients. Particularly because all the studies show that we may have a PCR in the axilla that may range from 35 to 63% in these studies. But if we look at a particular characteristics like HER2 positive and triple negative, we may have higher PCR in the axilla, even 82% if we do double block, trastuzumab plus pertuzumab. That now is allowed also in Italy, fortunately. But there are 4 studies that are exploring this problem, and we wanted to see if from a positive axilla that downstage to negative, we could do a sentinel node biopsy. but they didn't get the expected false negative rate that was considered less than 10%, similar to the upfront surgery. All of them found higher false negative rate, more than 10%. And so at the beginning they said, no, we have to do axillary dissection unless you look that using dual tracer, we may find less false negative rate, also by removing more than 3 negative nodes, or using a clip. And so international guidelines endorsed to reduce the false negative rate for these reasons by marking of sample axillary node with tattoo or clip, that is a TAD, or by using dual tracer and removing more than 2 negative nodes. This is the target axillary dissection that consists in putting a clip before neoadjuvant chemotherapy, and then they remove this also with the sentinel node that can be the same or may be another nodes. And with these methods, at the beginning, we can reduce the false negative rate. That was the problem that was solved with this technique. We have different methods to target the axilla, by carbon, by wire, by radioactive seed, by radar infrared seed, and so on. Everything will have more or less advantages. But we know also that with TADs, we may not retrieve the sentinel node in the node that is clipped in about 30%. But we know also, as I said before, that if we remove only one node, we have a false negative rate that range about 19%. That considered what I said before was not acceptable. But if we use more than 2 tracers, we can arrive to 11%. But if we move one node, we have 20% of false negative rate. But if we remove more than 3 nodes, it is very less, 4%. But all these efforts to reduce the false negative rate is very important. What do you think? I don't think it's so important, because we know that false negative rate does not change the prognostic outcome. And this is very well known from different upfront trial. We know this because all this upfront surgery found in the axillary dissection arm, in which they did sentinel node and axillary dissection, and the other arm only sentinel node. All this trial found a very high false negative rate in the axillary dissection. But what you can see, very low axillary recurrence and no difference in overall survival. So false negative rate is not a real problem. And I have 5 studies in which we don't do a TAD axillary dissection, but we do only sentinel node alone. And these are all the 4 trials with longer follow-up or less follow-up, in which we can see that axillary recurrence is very, very low. The first trial from Piltin showed that the median age of number of sentinel node removed was 3, but they found only 1 axillary recurrence, 0.7%. So they concluded that in these cases it has been incorporated into clinical practice. Another study, the study by Wrong, same with sentinel node alone, they found only 0 axillary recurrence in the arm that downstage to negative and received sentinel node alone. But in this case, they receive radiotherapy in the axilla. The study from the Sloan Kettering, also in this case, they remove more than 3 nodes with single mapping, and they found a very low percentage of node, 42% downstage to negative, and only 1 axillary recurrence, in synchronous with local recurrence in a patient that refused radiotherapy. All the other that did radiotherapy didn't have any axillary recurrence. And this is another study very interesting in Italy from the National Cancer Institute in Milan, in which they use only single tracer, and they had 33%, they removed only one single node. And in the group that you can see there, out of 122 patients that had a negative sentinel node, no one had a positive axilla in the follow-up. And they compared the 10-year overall survival between those that did sentinel node only versus those that received sentinel node and axillary dissection, and no statistically difference between overall survival and distant disease-free survival. This data from the EUBREST that collected 19 centers compare TAD with sentinel node alone. And up to now, you can see here the 5-year rates of any axillary recurrence, local regional recurrence, and invasive recurrence in entire cohort were very low, but particularly they found no difference between TAD and sentinel node alone about axillary recurrence, no statistically difference. And so they concluded that axillary section is an event very low, and so perhaps we may wait for more longer follow-up, but what the advantage they endorse that seems to be a reduction in number of lymph nodes removed. We started many years ago a study in which we did sentinel node alone in patients starting from CN0 that remain CN0 after NACT, or CN1-2 and downstage to CN0. And in this study, that was criticized because we had only 5 years of follow-up, we found very low axillary recurrence, only one case in the group that started from CN1 and 0. And we used only one tracer. We didn't change our practice compared to the surgery up front. But confident of this study, we go ahead and we continue our policy regardless the false negative rate. And now we published this study with 10 years of follow-up, and you can see that this is the design of the study. Those that downstage to negative receive sentinel node alone, and with sentinel node negative, they did no axillary surgery, while if the sentinel node was positive, they undergo axillary dissection. And what we look was not only axillary recurrence, but also overall survival and distant disease-free survival. What is interesting in this trial is that we removed in 50% of cases, only one node, the hot node that we found with our tracer. And with two nodes, 24%. So in 74%, we removed less than 3 nodes. But what we can see, we had only 1.5% of axillary recurrence in those that started with negative and remain negative and receive a sentinel node alone, while those that we are interested in are those that downstage to negative. We had only 2 axillary recurrence, 1.6%, that become 1.8 if we consider the 2 micrometastases that did not receive axillary dissection. So, and again, no difference after 10 years of follow-up, using the same technique for those that started with sentinel with a negative axilla. So our standard technique is not dual tracer, no target axillary dissection, and no limit of number of sentinel nodes removed. We don't try to find other 2 nodes. and no difference in overall survival and distant disease-free survival, low rate of axillary recurrence, and radiotherapy, we know that reduction of lymph node recurrence. PCR is an important predictor, particularly in HER2-positive and triple-negative breast cancer. What about the future? What to do if the sentinel node is positive after NACT? We wait for the Allen's trial and neonode for micrometastasis, and what to do with radiotherapy. So there are two important studies that we wait for the results. The SBP 51, in which we may reduce radiotherapy in those with a negative axilla post-NACT, and those with a positive sentinel node after NACT, they may receive probably only radiotherapy. And with this, I thank you very much.
Thank you, Viviana, for the excellent talk. And we can go on.
Okay, we can proceed with the next presenter, Dr. Karakatsanis Andreas, Associate Professor in Breast Surgery in the University of Uppsala, Sweden. Welcome, Andreas, again.
Thank you very much. This is a more controversial talk, and I'm a little bit more stressed because I'm doing it under my old teacher moderating the session. So let's see how that will work. So they told me the future of axillary surgery. The future has been touched upon in the two previous talks, but I decided to break down some of the questions that I have. So the key points here for this talk is that axillary surgery, we know that it is a field of continuing de-escalation, and we could reframe that if we have the adequate information without proceeding to that. But we need to choose when and what to de-escalate, because axillary surgery is not yet obsolete. And actually, escalating other treatments just to de-escalate on axillary surgery is not patient beneficial. Don't forget that the number of treatments, it's like a big menu that everybody is ordering what they want to have, but it is the patient that pays the bill in the end. So, we need to be very, very conscious of that. And anyway, in most of the predictable futures, the occasional axillary lymph node dissection will still be necessary, and we need to remember how to do it properly, we need to be able to teach it, and we need to be able to pass it on. And I mean, everybody's familiar with these types of diagrams, and what actually this tells us about what happened in the last 40 years is that we understood that this is a diagnostic procedure and seldom a therapeutic procedure, and we understood that biology instead of stage can play an important part in the equilibrium of what we make our decisions upon. So the questions, my personal questions for the present and the future. So in primary surgery, is it prime time to abandon any axillary staging for a DCIS? Any axillary staging for early invasive breast cancer? Upfront sentinel lymph node dissection in the low volume and positive, completion axillary lymph node dissection for the curious oncologist, and following neoadjuvant chemotherapy. Is it prime time to abandon any axillary surgery for clinically node negative to before and after that have breast pathologic complete response? Completion axillary dissection for the N+ that convert clinically but not pathologically. Completion axillary dissection in the N+ that convert but we do not find enough sentinel nodes, and completion axillary dissection in the pathologically positive following neoadjuvant endocrine treatment, because this is not touched upon. So let's break it down bit to bit with a couple of extra thoughts for the end, a little bit more provoking. You will see a series of black slides. These are the most provoking things I think can be part of what we will be thinking at some point. So, the omission for DCIS. We know that axillary surgery for DCIS should not be done because primarily it lacks the biologic rationale. If you've got a pure DCIS, you know that the rate of metastasis is very low and it is attributed to a false diagnosis from the pathologist. All the studies, both the Swedish and the British, that yield the 0.2, respectively 0.7, when they went back and they reviewed, they found a macro-invasive focus that they had missed in the beginning. So, no mystery there, right? It does not affect prognosis. It may affect treatment, but it does not actually affect prognosis. But it certainly increases the complications and the long-term morbidity by a relative risk of 6 to 8. regardless of what you do to the breast. So even in the setting of mastectomy, because somebody would be intuitive in saying, oh, a mastectomy cannot harm if you do a sentinel node. It does. It does by the same coefficient. And we should take this seriously because the standard DCIS patient is a more common patient in our practice, and we do not have the advances of systemic treatments over there. So we are already doing more extensive surgery in the breast for DCIS than we do for most invasive tumors. If you overdo it, because it doesn't cost anything, it will actually decrease the accuracy and the value or even the feasibility of a sentinel lymph node biopsy that you may need in the future if you get an invasive recurrence. And that is important because an invasive recurrence after DCIS yields the prognosis of the primary breast cancer in any case. So what to do? The refinement of preoperative workup with the routine vacuum-assisted biopsy has been able to reduce this postoperative upgrade rate, according to some series, down to 11% from the traditional 25 to 30 that we knew, but this depends on the extent of the DCIS. For example, in the prospective Cinnamon study, that upgrade rate was still 39%, even though they did multiple VABs, but they had DCIS with a mean size of 6 centimeters, grade 3s, and multiple clusterings and so on. This surgeon believes a lot in non-surgery, so the main advances with our understanding of biology of DCIS in its molecular profiling, the role of tumor-infiltrating lymphocytes that works completely on the opposite as it works to invasive breast cancer, EMT, and the use of traditional radiology, be that the classic MRI that is actually useless according to randomized and non-randomized data for DCIS, but the radiomics may find a role there, and some more advanced techniques like the concept of doing delayed sentinel lymph node dissection, which is marking the sentinel node upon breast operation by injecting SPIO, leaving it in place and going back only if you have an invasive focus that requires that. I will not extend more to that because that's a different talk by itself. With regards to early invasive breast cancer that is clinically node negative, we had Oreste Agrestis study already from '98, and now we've got more data from the sound that corroborates on what we know, that if you give adequate adjuvant systemic treatment and radiotherapy, actually nothing happens. And this is something that we knew from a very big cohort that we had in Sweden with 15 years follow-up, where the cutoff of the size was less. And you see that in patients that were followed prospectively very, very, very rigidly, that we had very big variances in the delivery of radiotherapy and endocrine therapy. Nothing happened, actually. And this comes to kind of verify what the Americans do with their Choosing Wisely campaign. However, is it prime time, though? Are we saving patients by doing axillary surgery? I think we can agree that the answer to that is most often no. But what axillary surgery does is that it defines systemic treatment decisions in many N-positives that are not clinically N-positive. So in the ER positive, the Natalie does not require 4 nodes, but the Monarchy does not. It is enough with 1 node if you have a grade 3, and you're missing on that chance. And these are drugs that show the more we follow them up, the bigger gap in the hazard ratio. So it means that we are losing the potential on a potentially meaningful treatment. In the CT1, T1, N0, the dual blockade will be advantageous. We were not very convinced about the advantage, but it is there. You cannot deny it. The evidence is there. And it is not compelling for everybody, but for the N-positive it is. With regards to the TNBC cancers, the choice of chemotherapy or the choice of a dose-dense regime, because the dose-dense regime clearly has better outcomes according to the Oxford Group meta-analysis, but it is a tough decision to make for any patient because it comes with higher morbidity and toxicity. Moreover, the axillary pathologic negative node status will allow for the escalation of radiotherapy, as we saw from the CALGB and more recently from the PRIME2 trial. So you have a patient in front of you that is either getting whole breast radiotherapy to avoid the sentinel node biopsy, or if she's N0 pathologically, she can skip radiotherapy. And that's not a decision for you to make, but for the patient to make. In the low-risk primaries, all these studies have not elucidated the role of dedicated radiotherapy, but they actually did it when partial breast radiotherapy was planned. And that's a big thing because all these things are coming to clinical practice. And finally, just a couple of weeks ago, the Oxford group struck us with their last meta-analysis on regional nodal irradiation, where you saw a survival benefit, a clear 4.6% survival benefit in the N1, even in breast-conserving surgery. So the idea that you do not do it because you don't need to irradiate kind of goes down the drain. It is challenged right now. And what we do is that we de-escalate something in order to escalate something more, but actually, if surgery in the axilla is diagnostic, then it needs to be accurate in order to be guiding the optimal postoperative decisions. Omission of axillary lymph node dissection in the low volume CN1. There was a debate before that. What I can say is that Vivian Mann from Hong Kong did a meta-analysis of observational studies that had low volume disease on an ultrasound. Usually they were clinically node negative but positive on the ultrasound. And she found that 45% of these patients are actually eligible in the Z11, Synodar, Otoazor, Amaros, pick your favorite. So that means that a fast-track axillary clearance would condemn 4 to 5 out of these people to an unnecessary operation. So primary TAD may be a thing. I'm aware of Peter Barry's data, and I think that they are very compelling. And currently, Walter Weber is looking at that in the randomized Taxis trial. Completion ALND for systemic therapy decisions. Yazan touched upon it. This is a problem that arose, but it is a non-issue actually, after the Monarchy and the R-Exponder. We have to think how trials are designed. So what did Monarchy go for? They went for what they expected to be the clearly high-risk patient in order to be able to have an easier job in demonstrating that their drug worked. The R-Exponder that instead of escalating wanted to de-escalate wanted the opposite thing. But we don't need to go back and revisit whatever we do. All we need to do is we need to do what we are supposed to do as we are supposed to do it. So if you got a preoperative ultrasound and at least 2 sentinel nodes, the data is very safe about the risk of N2 being very, very low. And actually, the Natalie requires any N positive. And I think that with time, the Monarchy indications will be explored in different settings, and they will change. But we do not need to clear axilla just because the oncologist is curious because they want to get approval. Going to neoadjuvant chemotherapy. If you've got a clinically node-negative patient from the get-go that remains clinically node-negative, and you've done breast surgery and you've got the PCR there. We know that the biology is dominant there, and we know from the meta-analysis of Baron and the meta-analysis of the EU breast that patients that have HER2-positive cancers and triple-negative cancers have a discordance of 1.6%. So the risk that you have breast path CR, but something in the axilla is very low. And that is corroborated by a small cohort study, a phase 2 study by Henry Curer and the Exceptional Responders trials, wherein patients that did not have axillary disease from the get-go, they refrained from axillary surgery and did just vacuum-assisted biopsies in the breast. And following local breast radiotherapy, but not axillary radiotherapy, Henry Curer presented in ESMO, I think, the 3-year results. There is no difference. There are no recurrences over there. And currently, the EU Breast 01 study and the ASIC study are looking into that. On the other hand, before we get too liberal, let's not forget that YPN plus is actually the strongest of all prognosticators for overall survival, disease-free survival, local recurrence, and loco-regional recurrence. And that takes us to the next question. So, can we omit ALND if we have limited disease? Traditionally, the disease following neoadjuvant chemotherapy and targeted therapies has been viewed as therapy-resistant disease. So that was the reason for our regression of going back and doing the axillary surgery. Now, these studies that are ongoing, as Viviana alluded to, are going to tell us if it is needed, or if vice versa, if you are node negative, you need to irradiate, but we are still waiting for some data. And I think that Giacomo Montagna's Icarus that will be presented in San Antonio with regards to isolated tumor cells will shed a little bit more light in how things work. But we should explore deciding on axillary radiotherapy and YPN and not clinical end status. I think that this is what the energy will tell us, what Ikro Meatin in the group in Florence are already implementing with good results, and there is a Dutch prospective study with regards to that. But we still have a lot to learn in this field. Omitting the ALND, in the patients that you do not get enough nodes, because we know all these things that we discussed about the false negative and Viviana analyzed so elegantly. So the data for time to event outcomes are these cohort studies that Viviana showed, and the results are promising, but it is not only a matter of false negative rates, but it is a matter of detection rate, and I will come to that shortly. Because the detection of positive disease will not save the patient by axillary clearance, but it will tailor decisions with regards to chemotherapy or complementary adjuvant therapies. And actually, all these studies that have these promising results from the sentinel node biopsy alone have one thing in common. They do not report on results that are in line with the rest of the literature. And this is what? So what is advantages with the TAD? You have an axilla that is originally positive, you have confirmed it, and then it becomes negative. You need to find something. You need a successful procedure in order to be able to avoid axillary clearance. And given the fact that according to Janine Simons's meta-analysis a couple of years ago, there is a big difference in detection rates from TAD to sentinel lymph node biopsy, this is why a lot of people, including me, would go for the TAD in this setting, because you do not actually have any medico-legal rationale at all to refrain unless you have patient consent from the very beginning. Simple as that. And there are studies that will be looking into that, the ATNEC, the TAXIS, the Minimax, the AXANA, they will give us results in due time. And yes, I agree that if you've got path CR in the axilla, nothing matters. If you obtain it by sentinel node biopsy or by axillary clearance or by TAD or by radiology, it does not matter. But you still need to be there in order to be able to make that claim. Neoadjuvant endocrine therapy.
Dr. Karakatsanis, time is out, please complete.
Yes, there are two slides, and I will conclude with that. Omission of axillary radiotherapy after neoadjuvant endocrine therapy. We need to understand whom do we pre-treat. So we usually will go for the postmenopausal that will have a low volume disease, and we do not have a standardized time frame for neoadjuvant endocrine treatment. We do not know if, we know that 3 months is not enough, we go for 6 months, we go up to 9 months or maximal response, but we still don't know. So, and we do not do it to give the benefit of axillary conversion. So the idea is that out of extrapolation, and this is what the NSABP people discussed, Terry Mamunas in particular, is that SLN with metastasis can guide decision as per upfront surgery, and in non-CN+, you could discuss radiotherapy and systemic therapy. And I will conclude with that. Axillary lymph node dissection should not be demonized. It is necessary when it is necessary. You will always have the patient with the occasional bulky axillary disease. It needs to be performed in a correct fashion. It needs to have adequate harvesting. It needs to be elegant surgery and not butchery with identification and preservation of nerves. It needs to be formally discussed in the context of direct lymphatic reconstruction, and you need to be able to perform it and to teach it and pass it on to the future generations. Thank you very much.
Okay, and after this great talk by Andreas, we'll go on with the last speaker of the session, who is Dr. Mario Marx. And he's going to talk about a totally different topic, the autologous transplantation to the axilla in the treatment of lymphedema, a topic of great interest to us surgeons. Dr. Marx.
Okay, thank you. It is a great honor and to speak to you today in this beautiful city of Athens, and to offer you my experience of more than 2 decades of a breast surgery. I would like to thank Cornelia who I have known and worked with for many years as a passionate and excellent breast surgeon. The fisherman on the slide is one of our patients who suffered for years of a persisting lymphedema after breast cancer treatment. It is my honor to explain to you how we treated her successfully in following minutes. Do no harm, be careful, and heal. This has been true for all of us from the first day of your training to the present. In Germany, approximately 11,500 women are treated for lymphedema of the upper extremities requiring therapy after breast cancer treatment. Whereas in the Federal Republic of Germany, we have approximately 7,000 cases of breast cancer per year. By establishing sentinel lymph node dissection, we have been able to reduce the morbidity of the arm lymphedema to about 8%, while we can demonstrate an arm lymphedema morbidity of about 18% with complete axillary dissection. I would like to present to you the concept of scar resection and reaugmentation for the treatment of an arm lymphedema and breast cancer. So the question is, why is the scar responsible for the development of a lymphedema? As surgeon, we all know that just removing the scar does not affect to a satisfying success. We have to augment and fill in the axillary space with vital fat tissue again. And we can do that using either pediculate perforator flaps like the turnover flap or free perforator flaps like the deep flap. I would like to introduce you to a 56-year young patient who is a colleague and specialized in internal medicine and anesthesia. And he has a number of diagnoses: Stiffman syndrome, intermittent third-degree FV block, autoimmune thyroiditis and hepatitis, factor V Leiden mutation, and has already suffered 2 leg vein thrombosis and arterial embolism. Conclusion: a serious ill patient. And this is our passionate fisherman from my introduction. In April 2021, a lower breast cancer was diagnosed. She received breast-conserving therapy with axillary dissection and radiation of the breast, and well as lymph drainage. A chronic lymphatic fistula forms in the breast and a second-grade arm lymphedema. We resected the irradiated remote mammary gland and completely removed the scars in the axilla. We then reconstructed both We resected the irradiated remote mammary gland and completely removed the scars in the axilla. We then reconstructed both the breast and the axilla with an FCI. I always catch smaller fish, but fishing gives me good ideas. Together with Professor Markus Hahn and our team in Tübingen and Radebeul, we were able to publish our method and results for complete scar resection and reaugmentation using the turnover flap. The rhombus of the former cancer in Germany symbolized very nicely the effect of the scars on the axilla. The scar pulls in the axilla vessels downwards, and this results in a kinking of the lymph vessels and blocks them to no flow at all. However, the large vessels are not affected by this. So the idea was born to resect the scar completely and to bring the vessels, artery, vein, lymphatic vessels, back to their original position, to prevent the vessels from being blocked again by the scar. We filled the axilla with autologous fat tissue. A scar is a temporary final state of successful wound healing after deeper tissue injuries. The tissue is repaired by replacing the lost tissue with connective or supportive tissue of lesser strength and functionally, but not with lymph vessels, and it destroys the regular anatomy. So the concept is to remove the scars and to rebuild the fatty part of the axillary anatomy. This is a patient after multiple breast conserving operation with wound healing problems. 1 year later, an arm lymphedema develops. What would you do? The scar is completely resected with preservation of the thoracodorsal vessels and nerves using magnifying glasses and ultrasound vision to granulize the axillary vessels. The scar in the axilla must be completely resected because the scar leads to a three-dimensional shortening in the axillary space and caudalize the vessels, the artery, axillary artery and vein, and the lymphatic vessels behind them. A singular scar cord may lead to caudalization of the axillary vessels and also a kinking of the lymphatic collectors located at the back of the axillary artery and vein. This is like a kinking of a garden hose. After complete scar resection in the axilla, a large space is created which is to be filled by the patient's own fat tissue. The large vessels will not caudalize again due to scar formation, and this will avoid a kinking of a lymph vessels in the future. For 20 years I have been using deep flap or FCI for autologous tissue reconstruction, microsurgical connection in the axilla to thoracodorsal vessels or arteria and vein circumflexor scapulae. Patients reported the joy of successful breast reconstruction. However, the joy of the improvement of the arm lymphedema was even more important to them. It is possible without microsurgical techniques to resect a tissue block with fat and lymphatic tissue, as well as good perfusion situation at the vessels of the artery and lateral thoracic vein, and to fix the tissue granularly after scar resolution in the axilla, the turnover flap. Indocyanine improves the lymph perfusion in the turnover flap. It's possible to see. This is an example for a biparticular deep flap in order to re-augmentate the axilla and to reconstruct the breast after breast cancer. The perforator are visualized using ultrasound and magnifying glasses. A preoperative contrast enhancement CT to detect the vessels is not necessary because of the ultrasound imaging. The axilla is very comfortable vessel supply reconstruct any kind of breast. We find different vascular lumina using arteria and vena thoracodorsales or arteria and vena circumflexor scapulae. And here you see another example. 67 years old female patient with breast cancer in her right breast, developing a lymphedema grade 2 and the right arm after axillary dissection and radiotherapy. Primarily, the patient did not want a breast reconstruction, but only the treatment of the arm lymphedema. After 1 year and successful surgical treatment, she decided to have a bilateral breast reconstruction. This example proves that the symptoms of the lymphedema is quite often more important to the patient than the breast reconstruction itself. It is possible to see connect the deep flap and not for the breast reconstruction, open the scar and for the fatty valve for the axilla. Okay. This is the result after unsuccessful omental lymph node transplantation and a secondary following unsuccessful lymphovenous fistula. We then use the turnover flap to treat the persisting lymphedema successfully. It is a very rare situation, but you have to have a treatment for these patients in order to reduce their symptoms. This one is a turnover flap. This is a transplant, the scar from transplant intestinal, and here was a scar. And now we augmentate with this flap, pedicle flap, in this free room. Okay. We saw patients after successful skull resection and reaugmentation using the turnover flap in these 3 patients who suffered from lymphedema for 19 years, 13 years, and 9 years. After 36 months, all of these patients are lymphedema-free and successfully treated. We evaluate the technique after the turnover flap since 2022 in a prospective trial, and the preliminary data show a successful lymphedema treatment in 70% of our patients. We have already included 68 patients. It is my pleasure, and I would like to take the opportunity to invite you all to the Congress in the German Society of Sinology in the next year in Dresden, Saxony. Thank you. Yes, sorry, my English.
This slide is obsolete. You did keep your time, so you
Okay.
so thank you very much for sharing with us your pioneer work in the field. And now we have our commentators. We'll give the microphone to Professor Kondos first.
I'd like to thank you all the presenters for their presentations. They are all experts in their fields. I'll start with my old friend Yazan. Yazan, you made us see axillary surgery not as a snapshot in time, but as a continuum. So you took us from the trial 04, 40 years later, and 20 trials later, going back to the idea that axillary surgery does not matter very much. I have to say that I became a breast surgeon because I liked clearances. So you added also that, yes, you think that in the future perhaps we may need do some surgery in the axilla for some types of breast cancer, but new treatments for specific subtypes might change this as well. Then Viviana, when I saw your paper that this house believes, I was shocked because it made me realize that FNR doesn't matter. False negative rates do not matter. What matters is, do they relapse or not? I have to say that these data come from a very highly specialized center, and I would be very, very interested to see a high FNR in less specialized centers, how they will deal with it. So we'll wait to see about that. I would like to add also that subtypes are important. I wouldn't mind doing an SNB in a lightly involved axilla of a highly chemosensitive patient. I would be more reluctant to do SNB after neoadjuvant chemotherapy in a patient with heavily involved axilla and with a cancer who does not have a chemosensitive cancer. So not everybody is the same. Then Andreas. Andreas, you gave us a glimpse to the future, a very quick one. Yes, we are convinced that DCIS more or less will never need, or nearly never need, any axillary surgery. We agree that for some types of very small tumors, axillary surgery is not necessary. I'm talking about upfront surgery now. And with regard to digging into the axilla to obtain enough number of nodes to allow us to give the right medication to the patient issue, I will say that I will agree that the monarchy and other studies will expand their indications, and at the end of the day we have radiology, which I think will be used in the staging of the axilla more and more. Even in Greece now, it was a year ago, that PET scans are allowed for breast cancer, non-metastatic breast cancer. As for neoadjuvant chemotherapy issue, yes, it is tricky because we are called to stage an axilla and treat an axilla, if we treat the axilla, or a condition in the axilla which is not there anymore, or at least is not there anymore in the form it used to be beforehand. So it's tricky. I agree we need more data on this. I join you in the idea that it doesn't matter a lot if you do this extra tad on top of S&B, because I'm not that brave. Yeah, you have to be there to know. You have to be there. And finally, thank you, Mario, for your presentation. Mario, sorry, you're behind me. I didn't know that this scarring of the axilla produces is the reason for this significant lymphedema. And I do think that the avoidance of clearance is the best means not to have lymphedema, but it is a good tool in our armamentarium to treat lymphedema. Thank you.
Okay, thank you. Does any of the speakers feel that he has to answer to Professor Kondos, or shall we move on to the next commentator? You didn't make any questions? Okay. So, Dr. Kondoulis is not with us, but Dr. Natsiopoulos, our co-moderator, will make comments on his behalf.
I'll try to be short. I'll make one comment for all presentations. Excellent presentation from excellent, globally well-known presenters. Finally, axillary surgery is only information, valuable information sometimes, but information. Let's stay on it, and let's take it with the lowest morbidity and toxicity. That's the comment. Thank you.
Okay, thank you. Dr. Lanitis, please keep your comments short.
Actually, it's quite difficult to speak after Mr. Kondos here because he's covering everything. So we're scrutinizing this thing about axilla for the last years, and we know that every year that it passes, everything that we've discussed the previous years is all just old news. Not many years ago, we were discussing whether or not to clear the axilla after a positive lymph node, and now it's just fact that we're doing that. I think we're getting there slowly, and the only problem is that how much info do we need, and how much risk are we willing to pay to get that info? Monarchy, yes, okay. We know that in Z11, about 13 to 14% of the patients, they're high risk, and they should have been taking CD46 inhibitors, but they didn't take anything, and they did well. So do we really need that info, and do we really need to overtreat all these patients by getting more and more info about the axilla? This is what we're getting. We're getting the oncologists, they want to give more, and we want to do less. And we need to find a balance between the two. The only concern about this is the clinical positive axilla, which is converted to clinical negative axilla. I think this is the only issue we have to sort out. We know that axilla is forgiving, so even if we leave things behind, it doesn't get anywhere. The only problem are the false negatives in case we get the PCR in the breast. And Andreas mentioned that if we have a negative axilla starting with, and then we get a negative axilla, it's only 1.6%. But if we have a positive axilla converting to negative, the false negative for the triple negatives are 11%, and for HER2 positives, there are 13%. So it's quite an interesting percentage of info that we may be missing in the false negatives. This is the only concern I do have, and I don't want to take more of your time. And I do have many questions, but I'm not going to address them though, because we're going to stay here forever.
Thank you, Sophocles. Is Professor Ans here? Yes, please.
So lots of comments, but not from all. So I would like to congratulate all speakers. Fantastic, straight to the top. So you started with the notion, and I think it's clear today, that axillary intervention is not a therapeutic, but it's a diagnostic intervention. I know it's still controversial, the topic, but some of us believe and some do not. It's like always, like in the church. I would like to make my comment and then we can have a controversial discussion. Second, I was sitting close to Professor Gianni Bonadonna. Once I was on a plane to ASCO back in the 90s. So I'm coming back again to that story that if you're old enough, you see a lot of things or experience a lot of things. So he said, Michael, we should not call the medical treatment anymore adjuvant or neoadjuvant or post-neoadjuvant. We should call surgery adjuvant or post-neoadjuvant, and I think we are more than there, because it is a very important part, but it becomes more and more targeted and more granular, as we have seen and heard from the discussion today. Now, I had the impression that there is some debatable opinion between Viviana and you, Andreas, concerning the TAT, targeted axillary dissection. So as a discussant, as a co-moderator or whatever you call it, I should not be on one side or on the other side, but I have to confess that at the moment, I think we still have to go for TAD before moving maybe forward to other scenarios. And in San Antonio, we will see some more data from Memorial. Actually, it's international data, but that is quite interesting. So again, it is not a big controversy between the two of you, because there is one single missing link. And this is what I'm telling, and I come back to my comment from before, because I'm also the speaker of the representative of the certified breast cancer centers in Germany. How can we bring those 1,000 horsepowers, which we produce in such illuster, fine scenarios and expert debates, how can we bring them back to our countries, to our practices, to our clinics, to our hospitals? Are we able to have that? And I would like to focus just on one thing. It is the pre-neoadjuvant or pre-operative or however axillary diagnostic. Are we able to skip those patients from more or less radical surgery, even skipping axillary intervention, if we see that the patient has no involved lymph nodes? You mentioned the topic of scans, PET scans. This is also one interesting topic which might come. But again, as for the moment, we have expert ultrasound. Do we have it in all breast cancer centers? And I can tell you from Germany, definitely no. So this is a problem. We need that information in order how to treat, including how radical we treat our breast cancer patients. And the last comment to Professor Marx. He is a crazy genius from Germany. I admire him very much. And I can remember, and that is my last sentence, I was doing with Professor Baumeister in Grossarden in München 35 years ago, the first transplant of lymph vessels. And I said, you must be crazy if you do this type of surgery or this type of intervention. And congratulations, because this is very skilled, high-level surgery, what you are doing. Again, you are a genius. Thank you.
Yes, most of your comments, thank you, Professor, were for Viviana and Andreas. Maybe one last comment from them, and then we'll have to close.
First of all, I want to say that it's not a faith, but there are data that we can discuss. But I am not against STAD. I'm only say that it's also very useful, because if you are more confident in the false negative rate, okay, you can do this. But I think it's more expensive. Not everywhere can do this. And so unless to do unnecessary axillary dissection, you might be confident also in doing sentinel node biopsy and not doing axillary dissection. This is the
For my part, I mean, those who know me know that I'm somebody that has few emotions and no opinions. For my part, the job needs to get done, and it's, as Mel Brooks used to say, potato, potato. The only thing that makes this discussion worth taking, actually, is what Michalis alluded to. In order to move forward and take 500 horsepower from the 5,000 we produce, we need to make sure that it has got a wide reach. So as long as data on detection rates suggest that there is a difference, the reason that we discuss the one versus the other is that we are interested in not how this will work in our hands, but in everybody's hands, because this has to be the common denominator. Thank you very much.
Okay, thank you. We have to close the session. I'm getting the look from the Congress President. Thank you all very much. Congratulations to the speakers. It's very clear to us that we're on a path to less surgery, and we stick to the Hippocratic motto, do no harm to our patients. Thank you very much.